Now, I myself was taught certain things about how insulin works and glucose dysregulation, but I found that when I went into the scientific literature, there's a lot out there that I was never taught. And I'd been to school and I'd been through seminars and I've listened to things, and it's just not out there. That in the genomic era, for example, in omics, metabolomics, and proteomics, and the genome, and the microbiome, and all these topics are getting all this attention, and with good reason, but we shouldn't throw out or forget about what some researchers are calling the low-hanging fruit. That with the information that's available today, with the cost effectiveness, with our understanding of some of these pathways that we're still learning about, even though insulin is almost 100 years old since its discovery, we're still learning more about insulin, and what I'll be presenting here is I think we're wrong about some of the things, quite honestly. As you will see, there are some theories about what's causing insulin resistance in the first place that makes you pause and wonder if what we're doing, even in nutritional or functional medicine, is a good idea by trying to get glucose out of the blood and into the cells. I could just jump straight to what to do. Here's the clinical and therapeutic interventions. But you know what? We as practitioners, or lay people even, our patients and clients deserve better. We need to step up our game. I'm not looking to create parrots that just merely repeat what they may have heard, but rather practitioners that can critically think and evaluate these things themselves. So where are we going then in this particular course? We're going to start off with physiology. The physiology of glucose dysregulation, or I should say the physiology of glucose regulation, because it's only when you know all the different hormones and how they work and the different mechanisms and second messenger pathways that you can then go and say, all right, well, what is insulin resistance really? What is postprandial reactive idiopathic hypoglycemia, which will evaluate all these different things that it's been called. Is it real? Is it not? What's causing it? But it's only when you understand the parts and how they work in the first place can you sort of critically evaluate them. Can you dismantle them? Can you take them apart and really identify what's actually going on? I'll just give you a sort of foreshadowing. There's a short section called the evolutionary benefit of insulin resistance, that there are papers and suggestions out there that we are here today because our ancestors were able to become insulin resistant, which enabled their survival during certain periods or certain situations. In other words, to say if you have a patient or client that comes in that has insulin resistance, does their body want to be insulin resistant? I have a colleague that talks about if something is the problem or a defense. And if it's a problem, we look at insulin resistance as the problem. We look at hypertension as the problem. We look at low vitamin D as a problem, as low cortisol as a problem, but maybe those are a defense mechanism by the body. Maybe the body wants insulin resistance, which then we'll look at some biomarkers. And the biomarkers are the blood chemistry markers that you can run on a panel to most effectively and most comprehensively really evaluate what's going on with somebody's glucose regulation or dysregulation. Evidence-based optimal reference ranges, so that it's not just about the laboratory reference ranges, but that maybe there's some studies that can back up having a more optimal reference range so we have a better target for health and not just the identification of disease. And then lastly, and only lastly, can we therefore look at clinical and therapeutic interventions for these different assessment biomarkers that we have. Logically, you'd think that an infusion of glucose directly in the bloodstream would cause this huge surge and spike of insulin versus the oral, but that's not what happened. And I'll say this in a different way. When you consume oral glucose, you have a higher, faster, and more pronounced insulin response than if you were to inject glucose directly into your bloodstream, which is totally counterintuitive. So when glucose goes up in your bloodstream, goes circulating past your liver, goes throughout your bloodstream, it's going to make its way to the pancreas, it's going to make its way to the pancreatic islets, and it's going to make its way into a beta cell. Now here we have a beta cell. So I'll just ask you this now. If this pathway still works in the case of insulin resistance, is it a dysfunctional receptor? Is it a dysfunctional insulin receptor substrate 1? Because to me, just thinking about this logically, if the glucose pathway doesn't work, but the RAS-MAPK pathway does work, then to me, I would say that in insulin resistance, the receptor is still working, the transduction is still working, and the insulin receptor substrate 1 is probably still working. So we'll cover that. So in this particular video, I don't have as much to draw on the board, but I have a lot of papers to show you. So we'll be flashing some of these up on the screen and reading some of the text directly out of these papers to help inform us of where we're going. So this first paper I want to show you, when you look at the title alone, the title is pretty clear. It says, Insulin resistance is a cellular antioxidant defense mechanism. And they go on to say that this hypothesis is exciting for a number of reasons. For example, it suggests that insulin resistance may be a protective mechanism, in which case we should perhaps reconsider using therapeutic strategies to overcome, unless they also eliminate the primary defect. So what they said is that this is exciting because we found something that might be upstream of these other things that are supposedly causing insulin resistance. So here's a couple really interesting papers to strongly suggest that low blood sugar, really low blood sugar, does not always correlate with low blood sugar symptoms. But so then your question should be right now, well, what the heck causes too much GLP-1 in people? We just learned earlier that there's a bunch of people that need more, so why do some people have too much? Well, it's interesting, some very interesting papers on that. So take a look at the screen. I do not believe that we should be teaching laboratory markers without teaching the underlying physiology first. So based on that, I propose that in US units, a healthy optimal reference range for glucose is about 80 to 90. And the way that this works, there's something called a hazard ratio. A hazard ratio is the increased relative risk of a given thing, in this case coronary artery disease. One of the things that I say is this concept of glycemic variability, is that going to be the end of the A1C era? Which is to say, if I had to choose between those two, if I was to choose between chronically elevated glucose or glycemic variability, I would choose chronically elevated glucose. Whether it's nutritional or pharmaceutical, I don't know that, just based on everything we've seen in these videos, you guys, that maybe the body wants to be insulin resistant, and maybe trying to just merely get glucose out of the blood and into the cells is not necessarily the best strategy, and that's what we're going to talk about in this particular video. You want to, and hopefully you already have this answer, if I were to ask you right now, which person that we've talked about needs GLP-1 stimulation? The answer should hopefully quickly come to you and say, anybody that has a blunted first phase insulin response, who has too much postprandial glucose, GABA is released from the beta cells, and when it does, essentially suppresses glucagon. So insulin is said to suppress glucagon, but it does so via GABA.